Thank you very much for the opportunity to speak at RSSDI. We are still on a virtual mode right now, and hopefully I'm unable to come. I know there is a hybrid going on this time, but very happy to be a part of this. Thanks to Banshi sir and all the others at RSSDI. So today I've been asked to speak on cluster drug response, and I have no conflict of interest to declare. So what is this cluster drug response? So first is we have to say, what is clustering of diabetes? And for that, we have to ask the question, is all type 2 diabetes the same? Well, obviously it's not the same. Those who are thin are different from those who are a little heavier. Those who are younger onset diabetes have differences from older onset diabetes. There's differences in rates of complications and differential response to drugs, etc. So in Scandinavia, the first attempt at clustering type 2 diabetes into different subclusters was done by Leaf Group and colleagues. And what they did was that they took about 8,000, 9,000 individuals from the Swedish Scania cohort, and they clustered based on all diabetic patients they took, and they clustered based on these 6 variables: the GAD antibodies, age at diagnosis of diabetes, BMI, A1C, HOMA beta, which is a measure of insulin secretion, and HOMA IR, which is a measure of insulin resistance. So they clustered based on this and got subtypes of diabetes in this population. They then replicated this in few small cohorts. You can see 4,800 people, 3,000 people, etc. So this is what they first did. Now, these are the clusters that they had. They had 5 clusters, all of diabetes together. The first one is called SED, which is actually another name for type 1. So we won't talk about that anymore. But among the rest, we have 4 subtypes of diabetes, which was SID, which stands for severe insulin deficient diabetes. Then they had SIRD, which is severe insulin resistant diabetes. Then they had MOD, which is mild obesity related diabetes. And the last is MARD, or age related diabetes. So these were the 4 types of diabetes which they applied. So then they said, we asked the question, can this then be applied straight away to the Asian Indian population? Now, Asian Indians have a unique phenotype, which all of us know about, right? We have a greater susceptibility to type 2 diabetes. Why do we have this? The diabetes that we have, if you look at the ICMR INDIAB study, which is a national study on diabetes and related risk factors, you'll see that the age of onset for diabetes in the Asian Indian population is in the age group of 25 to 34 years. Now, you take any other Western Caucasian population, you'll see that this is somewhere in the 50s. So you have a shift to the left by a couple of decades in our population, with younger and younger people getting diabetes. Moreover, you'll see that these are very thin people. So they are thin in the sense that they have a low BMI. They may or may not have a low birth weight. But if you look at them, they have a lot of visceral adiposity. So they have thin arms and legs. The BMI may be a little low, but they have a lot of visceral fat. So that is a particular kind of phenotype that we have. We also have high levels of insulin per se due to insulin resistance. We have low levels of adiponectin. We have a lot of the inflammatory markers, CRP, etc., and a very characteristic dyslipidemia where we have low HDL, high triglycerides, and high small dense LDL. So it's not just the total LDL, but the type of LDL, which is small dense, making it very atherogenic. So suffice to say that all of this gives us increased risk of type 2 diabetes and premature cardiovascular disease. So this is a collaborative study between the Madras Diabetes Research Foundation in Chennai and the University of Dundee in Scotland. The study is called INSPIRED, which stands for India-Scotland Partnership for Precision Medicine in Diabetes, and is funded by NIHR UK. So the first thing we did was try to apply the same exact thing of Scandinavian population into the Indian population. So if you look at this, now first they had, let's take BMI. So BMI in SID was obviously the lowest, okay? And then they had the highest was, of course, in MOD, which is their obesity related. Now, compared to Indians, the obese people were actually not very obese. Look at the obesity rates here. BMI 24 for SID, 25 for MOD, and it's higher in the insulin resistance group. It's higher in the MARD group. So suffice to say, and if you look at all of these parameters, they are not sitting very well in the Indian population. So we could not replicate the Scandinavian clusters as is in the Indian population. So then we said, okay, we are not able to replicate it. Can we make our own clusters? And this was the publication that came out in July 2020, where we reported independent subclustering of type 2 diabetes in the Asian Indian population from the INSPIRED study. The base population or initial discovery cohort for this was from the Dr. Mohan's clinics. We studied 19,000 individuals with new onset diabetes less than 5 years from diagnostic visit. These were included into the study. Now, the clustering variables which we took were different. They were based on the Asian Indian phenotype. So we had 8 of these variables. So age at diagnosis, BMI, waist, HbA1c, triglyceride, LDL, and we also had C-peptide, fasting and stimulated. So all of these variables went into our clustering. And these were the subgroups that we found. So 2 of them are very similar to the Scandinavian clusters. The SID, which is the severe insulin deficient diabetes, is the same. And the MARD, the mild age-related diabetes. So the first and the last are similar to the Scandinavian clusters. But we do have 2 novel subtypes which have been described for the very first time. And that is the IROD, which stands for insulin-resistant obese diabetes. So what we found is that in the Asian Indian population, obesity and insulin resistance go together. So we are not able to separate. In the Scandinavian, we were able to show separate insulin resistant type, separate obese. For us, it appears to be combined. So when you have obesity, the insulin resistance goes along with it. So that was called the IROD. And the most novel one is called SIRD. So this is described for the first time in the world, wherein they have a combined deficiency of insulin deficiency and resistance. So it's a kind of in-between between SID and IROD. So if you look at all of their characteristics, it will be between these 2 populations. Now, the importance of this is that being combined, it's double the trouble. So that's what happens. There's increased risk of all the microvascular complications, as we'll see in a minute. So these are the cluster phenotypes. Not to scare you with a busy slide, but just a few key points. What is the age at diagnosis for this population? For MARD, it's about 50 years, which is quite young. In any Scandinavian population, you will see that it's above 65. So even the WHO defines aging to be, elderly to be at 65. But for us, even at 50, 55, we are seeing the MARD cluster that's coming in. Now look at the other clusters. Look at the SID, the insulin deficient variety. These are the lean, thin diabetics. And all of us have seen this in practice. Look at the BMI is very low, waist is very low. Look at IROD. So that becomes the highest. So this is the most obese category. This is the thinnest category. And SIRD is somewhere in between for both of these. A1C, of course, the insulin deficient varieties, which is SID and the SIRD, have high A1C, very high triglycerides in the SIRD, and very good HDL in the MARD. So these are the kind of characteristics that we have. If you look at the C-peptide and HOMA and all that, it will follow the same correct kind of characteristics, wherein it's lowest in the SID and highest in the IROD, as it should be. Now, remember I said that we took new onset diabetes less than 5 years. So did it change when we took less than 3 years, less than 1 year? No, it didn't. The clusters remain stable even with the other data sets. Now, I've told you about the clusters. Remember I said that the base population for this came from a clinic. So the obvious question then is, how can you extrapolate this to India based on a clinic population? We don't have epidemiological evidence. And thus we took the data from the nationally representative data set of India, which is the ICMR INDIAB study. Now in INDIAB, we had 6 of the 8 variables used for primary clustering. So we had age, BMI, waist, HbA1c, triglyceride, and HDL. We did not have C-peptide alone. So without that, we were able to recluster. And if you remember the previous slides, what you see, so MARD here is 55 years, just like in the hospital clustering. And look at the BMI, again, lowest in the SID, highest in the IROD, glycated hemoglobin high in the deficiency states. And everything is kind of mirroring the exact same clustering variables. Up to decimal point, it's almost the same. So this was able to show that the clusters remained stable and had a stability index of 0.75. We were able to replicate this at a national level for all of India. So what is the clinical relevance of this clustering? It is the risk of microvascular complications. And thus, these are the Cox hazards ratios, which talk about which of the complications are more prevalent among the various subclusters. So as you can see, retinopathy is very high for SID, is 1.5 higher times of getting retinopathy, but even SIRD, so this is the combined group, has a very high risk. If you look at nephropathy, and this is by albuminuria, both micro and macroalbuminuria, you'll see that SERD alone is significant, and CKD is by GFR. So IROD, as you would expect, but SERD is also there. So the importance of this, look at this. In every category, you see that the SERD is coming out as significant, and this is what is quite important in this clustering. Now, we're coming to the drug responses among the clusters. Now, for this, we took a separate population. So these are the contributing centers who give data for the study. And you can see it's the who's who of diabetology, and everybody in RSSDI is here. We had from 12 of these states and 1 union territory, a total of 15 centers contributed 32,000 data points into this study. The first thing we did, of course, was recluster, and not to take you through those complicated tables again, but we were able to again replicate in this new cohort the same 4 clusters of SID, SERD, IROD, and MARD. Then what we did, we had to look at drug responses. So we had baseline drug available in 30,000 individuals. We needed a HbA1c follow-up. For 14,000, we had that. Then after all the cleaning and removing all the other stuff, we finally had 13,000 individuals in whom we could study the drug responses. So this slide here is busy, but it tells you the prescribing patterns of which drugs are given for type 2 diabetes in the country. So if you so just to tell you here, the disclaimer here is that it's a retrospective analysis. When we remember, we just got data from people with those with new onset diabetes and their drug patterns. That's how we have studied this. When physicians were prescribing, they did not know anything about SID, IROD, or SERD. They were just prescribing for type 2 diabetes. So from this, we know that in India, the commonest drug prescription for new onset diabetes is a combination of traditional drugs, the sulfonylurea and metformin. Although we talk so much about the newer drugs, it's quite surprising to see that still maximum, the cheapest and most efficacious drugs are sulfonylurea and metformin. Now, contrary to that, all guidelines say that we should first start with metformin. Are we doing that in a small percentage? But primarily metformin alone is not being given. We are giving in combination with sulfonylurea. Among the newer drugs, the ones that is being used is the DPP-4. So maybe it's because SGLT2 are still newer and they still have to go off patent and things. But this is the usage pattern which has been described and published. Now, the last part is to look at whether or not. So all the guidelines say that for any type 2 diabetes, metformin is the drug of choice. But among these clusters, are there drugs which are more efficacious than metformin? And should we prescribe maybe something else in subclusters and see which is the best drug to be given in the best cluster? And that is what this analysis is about. So metformin is here. We have shown you SID and SERD, with both insulin deficient states. And in this, we see that metformin is given as reference. So obviously, insulin did the best here. These are insulin deficient states. So you can see what the numbers mean is that there is a 13% extra response over and above metformin in bringing down A1C in this category. So for SERD, you'll see it's 20%. So 20% extra response. So what this means, these are huge numbers. What this means is that perhaps in these two, early insulinization is the key, and giving insulin early. If you identify these two, remember these are also the ones that quickly progress into retinopathy and CKD. So giving insulin early aggressive treatment is possibly needed. In addition, you'll see sulfonylureas and DPP-4. So the secretagogues are also working well in these groups. Whereas if you look at the IROD as well as MARD, in MARD, you'll see that nothing actually is working better. Metformin is a very good drug. Similarly, even in IROD, the sensitizers are working better. Of course, insulin does have good effect in IROD as well. But you'll see that the sensitizers. So suffice to say that across the clusters, we do have differential drug responses. And we maybe should not be just blindly giving any drug to any cluster. It's possibly good where we see that in each cluster, which drug is responding well, where we have to start insulin, etc. So to do this in the primary care setting, we've developed this tool that's called Diana. What it does is that so you've just put in these variables, the 6 variables we had: age of onset, BMI, weight, A1C, triglyceride. HDL. If you have C-peptide, good, but you can also predict without the C-peptide, and you enter these values, the tool gives you a risk of what you're dealing with. For example, if you're dealing with SID or SIRD, it will tell you. It will also tell you what is the risk of retinopathy, nephropathy, etc. And it will also tell you what is the best drug response in this category. So this is the tool that's been developed, will be good for primary care settings. So I'd like to summarize and say, for the first time in actually South Asia, clustering has been done in type 2 diabetes, and subclusters have been identified, two of which are similar to the Scandinavian clusters, but we have two new and unique clusters, and that's the IROD and the SIRD. The SIRD is of particular importance because it has difficult to treat hyperglycemia and increased risk of microvascular complications. In addition, we know that in India, traditional anti-hyperglycemic agents are still used widely, and identifying these phenotypes, giving drugs according to the phenotypic characteristics, may be the first important step towards precision and personalized diabetes care in this country. However, RCTs are needed. Now, all of this is retrospective analysis, and thus they're confounded by the baseline A1C. So that is the biggest limitation of the study I showed you. And we do need large RCTs to confirm the differential drug responses between clusters. Thank you.